Hello everyone, this is Chadi Alraies from SIF 2024. We're celebrating the 20th anniversary. With me is Dr. Katherine Harrington. We're going to talk about, she's a CV surgeon at interventional meeting, which comes every year. Thanks for joining us. And one topic is about TAVR explant.
Yes.
As we are doing more TAVR in low-risk patients, so this is going to become a little bit more common than before.
Yes.
Thanks, Katherine, for coming.
Thank you. Thanks for having me. This is a really big topic, obviously at meetings like this, but in surgical meetings too, it's becoming a very big debate, not just a debate, but a term room for learning. So, I mean, I think we never really thought about that when we were first putting TAVR in. We thought about TAVR versus SAVR, and now we're getting to the end where we're starting to have to take some of these valves out. I think we all thought it would be about the same mortality as a first-time SAVR, because it's not a redo chest, but that has not been the case so far. And so the question is whether these patients are just a sicker population, or whether we just need more dissemination of techniques. I think we can get it down, but that's the big push right now at all the surgical societies.
Who would need explant of the TAVR?
What do you mean?
Who would need, who would need, which patient?
Oh, who would need, yeah. So obviously, any patient that has endocarditis, needs to be surgically explanted. And then anyone with patient prosthesis mismatch or structural valve deterioration, it's a debate if they should get explant or a TAV and TAV. A lot of obviously if it's a small valve and they have PPM, then we're leaning towards explant as opposed to putting another one in. But for just straightforward structural valve deterioration, I think that's the big question, is what's going to be better for the patient, a TAV and TAV or a TAV or explant.
Right.
And there's some issues with sizing, coronary heights. That's what all the research is going into right now.
Is there a specific valve that this population will get into? Is it a suture valve or is it a sutureless valve? Which one will be a candidate for?
To put it in after you explant. Once you've explanted the valve, then you can just proceed with an aortic valve replacement as normal. You have to obviously explant the TAVR and the native leaflets that are still there. But at that point, you can really do whatever you want. And again, we're looking at that, looking at the anatomy ahead of time, the size, to know if we need to have to do a root enlargement or a root replacement. Those are all things that we've kind of copied from the TAVR world, where we know exactly the shape and size of the annulus now before we would even go in and do it.
From your experience and the database or registries that you have now, is it more people with low risk undergoing the explant, or is it a spectrum?
It's still, so the current TAVR explants are still relatively recent after TAVR, so I don't think we're quite getting the low risk people that just started getting put in a couple years ago. The average time to explant is relatively short, I think 45 months. So, these are not patients that had their TAVRs that long ago, and I think they're still more for endocarditis or different reasons. Once, whenever low risk was cleared with 2022, we're going to get a big, in 10 years, hopefully there'll be a big rush, but I'm optimistic that we'll be able to have refined our techniques well enough that it'll be a safer operation at that point.
Just segue to root enlargement.
Yes.
For aortic valve.
Yes.
How often we use it, and I know there's a recent trial published about the root enlargement for aortic valve, but what is the practice now, and what is the...
So we just did a look at our own data, and the overall STS root enlargement is only about 3%, but in a big center that does a lot of TAVRs, we're up to 10 to 15%. I mean, some of those patients that are getting surgery are large bicuspids that don't need a root enlargement, so that's just the overall percentage. But basically my rule is I won't put anything less than a 23 in a woman and a 25 in a man, and I'll do whatever it takes to get that. There are other people like the Michigan group. Surgically, yes. There are other people like the Michigan group who are much more aggressive, and they do the Yang or the Wyron maneuver to get a 27 or 29 in everyone. I'm not quite that aggressive. I kind of try to tailor it to BSA, but those are both different techniques that the surgical community is doing right now.
Great. Well, thank you so much, Dr. Harrington, for being with us, and for a great overview of explanting TAVR as well as root enlargement for SAVR procedures. Watch these videos and others on the YouTube channel. This is Chadi Alraies from SIF 2024. Thank you for being with us.
Thank you.